So injection techniques for the mid-face, and that's the area that you get the best bang for your buck, because that's the area that people really focus on, the cheek, the beautiful cheek. And I'm going to give you a couple little tips on injections because we all inject the mid-face. This little guy over here, as you notice, is not at the infraorbital rim, but it's usually 5 to 8 millimeters below. And it has a tendency to wander just a little bit. It could be at the inside of the iris, it could be at the mid-pupil. Sometimes you can palpate it on a patient. They'll feel a little bit of a funny feeling when you go ahead and you feel for it, but that's the area that we want to avoid. So when I look at injections for the mid-face, the first thing that I say to myself is, what does the face want? What is the mid-face telling me that it wants? Because these cheeks will talk to you, and sometimes they'll be screaming at you, give me volume. Okay? So what does the face want? I mark out the area that I think the face might want some filler or some volume. And then what I do is with my pencil, and it's never really a pencil, it's a confidence tool that you have because it tells you where you are anatomically on the topography of looking at the patient's face and then being able to understand what's going on underneath. I establish a line in the sand. And that line in the sand is usually at about the outside of the pupil, maybe just at the iris, and I draw a vertical line down there, and it divides that cheek, the upper part of the cheek, into a lateral and medial region. When it does that, what it tells me is that the lateral region is a safer zone to inject, there's no safest, and that a more hazardous injection is medially. Now, because of the studies that were done, and because of the fact that I hate to go into the medial cheek unless I must absolutely have to, I typically was always injecting the lateral cheek first. But the studies have shown that if you do lateral before medial, you use less product. It's what I found intuitively, but it's been shown through studies that when you start with the lateral cheek, you precondition the medial cheek. And if I never have to go there, I'm a happy camper. So I draw that line down there. And then I have to decide what I'm going to do for the lateral cheek. Everything in the cheek for me is suspensory. Okay? Unlike where you build a foundation in the lower face to support the features of the lower face and the chin, I believe that things that you build in the mid-face suspend from it. So you want to be able to create something that will suspend the cheek. So I inject higher areas before lower areas. I inject lateral before medial, and I inject deep before superficial. Why is that? The deep fat doesn't move. It's attached to the bone, and probably it's there to allow muscles to glide without wearing out over the bone. So the SOOF, which is deep, is going to stay there. Any product that I put into the SOOF, theoretically, will stay there. It might be affected a little bit during smiling because of that transverse facial septum. We'll talk about that. But most of the movement that occurs in the cheek is happening in the superficial fat. If you put everything into the superficial fat, when the patient smiles, they'll drive that fat up, because that's what the muscles of the face are designed to do, is to lift for the smiling and to lift the mobile part of the cheek, and they're going to look like they have two apples in their cheeks. We call it apple cheek. So I try to target deep before superficial, lateral before medial, higher before lower. It's just setting up a system, if you're systematic like that, that when you look at your syringe after you do your cheek injections, you'll be amazed at how much product is left in your syringe, because you're doing it in a fashion where every injection preconditions the subsequent injection so that you need less with this next injection, okay? I'm not a big believer in volumizing. I'm more of a believer in structurizing or projecting. And projecting in the cheek is something that we want to do, but we want to do it in the right direction. If you look at the maxilla over here, the maxilla has an angle to it, which we call the maxillary angle. Piriform has an angle to it, which we call the piriform angle. Which way is that cheek facing? It's facing down towards the toes. Do you see that? That's where your cheek is angled. So, if you were to put the positive product right over here on the cheek because you want to project it, and you put a little product like that, you get projection forward, but in which direction? Down. It has to be. It's projecting down like this. So you'll project the cheek forward, but you're going to project it inferiorly a little bit as well, okay? If you use what I call the double scoop technique, where you go ahead and you put a small amount of product there, and then you withdraw your syringe just a bit, your needle, and put a second bolus on top of it, that'll sit more like this. See if I can do that over here. There you go. Now which way is it projecting? Up or even straight forward? And you'll find that you need less product to get the result that you want. You'll project forward. So I call it, it's like going for 2 scoops of ice cream on a cone. They put the first scoop in, and the second one of hard ice cream, they kind of mash it into the second one. So the idea is, if you're doing this with a needle, is you go down to bone, you put in about 0.1 cc of product, you come off the periosteum just a little bit, you lift your needle up, and then you put in your second bolus of 0.05 on top. And that little bolus will have a profound effect on not only projecting the skin, but it'll have an effect on the lower tissues of actually elevating them just a bit. And I'll do that for several little pillars over here. And then you can use your cannula over the top if you have to make a canopy to go ahead and to volumize the rest of the cheek. As Sebastian was saying, once I get to the middle part of the face, once I get past that mid-pupil or lateral pupillary line and I want to inject in this area, I have one of 2 techniques that I like to use. Technique number 1 would be to make a bolus over here, right there, and then to use the safest thing that I possibly have. I'm down on periosteum. I use the safest thing that I possibly have to go ahead and to get that product to move over, which is my finger. You can't go intravascular with your finger. So it's a bolus and a push, and I actually milk the product slightly over. It all depends on where you are over here with respect to the ligaments of the face, which Sebastian's going to show you very quickly in a second, because you have a ligament that's going around the orbit, and you have a ligament that's going from the orbit down across the cheek, and it forms like a V, and that's where the SOOF ends. So you can advance that product only to a certain distance. So I'll either do bolus and push, or I will come from a lateral aspect like this and come across to go ahead and to fill this area, because I can't get into the hole that way. But if you take a look, do we have a pad here? We can clean that up. Okay. Look at the way the maxilla is shaped like an upside down V or a funnel. And you can understand that if you're coming from below, only thing that it's going to do is lead you into that foramen over here, if you come from below over here. So you're always best off coming from a lateral approach or from almost a 3/4 approach this way, because that little hood of bone over here will protect the vessels. And I've had patients referred to me, 2 of them actually, where there was product jammed inside there that they had intractable pain because of the fact that it was compressing the V2, the second branch of the trigeminal nerve over there. Okay? So it's over here, you're in a safer zone. You can use cannula or needle as you please. You can stay on periosteum. You're staying in the SOOF. My big contention is the fact that if I can avoid putting filler inside a muscle, I'm a happy camper. Because muscles don't want filler to be inside there. They're constantly moving and squishing. And that's where you start to get these delayed reactions where a couple of months later the patient just blows up because there's a foreign body in there. There's a house guest that they don't want. Okay? You have a house guest for a weekend, everybody's happy. You have a house guest for a couple of months, boy, something you're going to do, or that house guest is going to do, is going to piss you off at some point. So I like to try to avoid the muscles if I can. By putting it into the SOOF, I'm suborbicularis. It allows the muscle to glide over it and everything's fine. If I put it into the mobile fat pad over the orbicularis, it'll move with my movement and it will cause a little more volume when the patient smiles. When it comes to the tear trough, now it becomes an interesting situation because of the fact that the skin is so thin over there. And Sebastian can show you that I think if he puts his instrument underneath, you're going to see basically the color of the instrument. It's why we say that the tear trough is the easiest area to inject poorly. I don't believe tear trough is a deformity. I don't know how it got a bad rap by calling it a deformity, because it's not a deformity. My kids had tear troughs from the time that they were born. Most people do. But some kids have baby fat. The baby fat isn't in the SUF, it's in the superficial fat, so they're coating over that area with superficial fat. But as we mature, we lose the baby fat. And so that tear trough becomes more evident. So what it is, it's not a deformity, it's a revealing of anatomy. Okay? And I always felt that a lot of the surgeries that we were trained to do, which was to disrupt the anatomy of that area to try to fix it, was really slipping down the mountain rather than really taking on what was the problem. And I think it's more of a volume issue. So that I like to replace the volume of the tear trough. The difficulty with the tear trough is the fact that the orbicularis muscle is firmly attached right there, correct?
Yeah. This is what I just also wanted to show. During the dissection process, I'm of course going up into this area, but here you can kind of see that it's not kind of like the muscular attachment is not like a straight line, it's more of an area here. And this area, during the dissection process, I'm dissecting it and I'm detaching the muscle from the bone so you can have a better visual on this one here. But again, the orbicularis has a patchy area where it's connected. It's not a straight line like most of the other muscles. So always keep this in mind. When you do your tear trough treatments, sometimes you also are able to detach the muscle from the bone, which is also not good for the muscle.
And it hurts. If you go in with a cannula over there, you're on periosteum, but you're going intramuscular. It's such a thin little area that it's very hard to distinguish between the two. But you can't get under the orbicularis over there like you can more laterally where there's SUF, right? Mm-hmm. And so I'm very hesitant to use a cannula there deep. If I am going to put any product on bone over there, I'm using a needle, and I'm using it very, very gently in a very small amount because the product is going directly into the muscle just like it does in the temple. It's the exact same thing. And the patient's blinking 1,200 times an hour, they're squeezing your product 1,200 times. When they squeeze your product, the product is looking for the easiest way to get out of that area, to glide out. It can't go medially because everything is stuck down. So what does it do? The product starts to excurd downwards, and it will accumulate like a ball, very typically at the medial iris, which is the end of the tear trough. And that's why patients will come back 3 or 4 months later when you did a beautiful tear trough, and all of a sudden they have a blue ball underneath their eye and they're swelling. You can always spot them the second they walk into your clinic because they have that Tyndall effect, that bluish discoloration that you see, a reflection, a scattering of the blue light. So I try to leave as little product as possible inside the muscle over there, and sometimes what I'll do is I'll use a cannula, but I'll go over the muscle, between the muscle and the skin, which is a very, very shallow layer that you can get into, but there is no resistance. Your cannula will pass very easily. And then using the palm of your hand, you very gently coat that area with a very thin amount of product. Any thin amount of product won't Tyndall over there. It's only when it thickens up that it Tyndails. So it's a 2-layer approach that I do for the tear trough. It's a couple of little drops on the bone if I have to with a needle, trying to keep the product out of the muscle as much as possible. And then it's over the top of the muscle with the cannula, very, very thinly, trying to leave the muscle alone to do its work. And that's the trick. So here we're under the muscle or above the muscle. Here we do the exact same thing. We try to stay under it, although we can't get really under it or above it. When it gets down to the lower part of the cheek or the submalar region over here, you saw all the vital structures that there are over there. There's nothing deep over here except teeth and problems. So that my treatment area for the submalar region is superficial. So now you start to understand how you can divide the face into zones depending on the depth of injection, because you're now seeing the anatomy and it will remind you when you're injecting, where am I supposed to be? It's not just sticking a needle in here, but how deep am I supposed to put that needle or how deep am I supposed to put that cannula? So for me, it's always superficial, beneath the inferior border, which you can feel very easily of the maxilla, except for the gonial angle, which we'll talk about when we get to lower face. But otherwise, I'm staying superficial here because you have parotid duct, you have facial vein, you have all these things that are there that I don't want to play with. Over here, it's superficial or deep, but I don't want to stay in the muscle itself. And over here, I told you it's a lateral approach or inject and push with your finger. And that takes care of the whole midface as far as injections. And you choose your product according to the type of skin that the patient has. If they have a very thin skin, then you go with a lower G prime product. If they're very thick-skinned, if they're Asian, large pores, Afro-American, whatever the story is, and they have a thicker base to their skin, okay, then you go ahead and use a more robust product that's going to be able to push the skin forward. And that double scoop is going to save you a lot of product. It's going to make it more economical for the patient.
What about piriform fossa?
What about that piriform fossa? It's my favorite area to inject, and it's probably the most hazardous area to inject. Fair enough?
Mm-hmm.
We were talking about this earlier, and the question is the fact the facial artery is coming up, like Sebastian showed you. It gives off the superior labial branch for the lip, and then we call it the angular artery because it's angled. Very often now, Sebastian has shown us that that artery will continue into the nose and end there. It doesn't even connect to the upper part of the face.
Like in this instance, it doesn't go straight.
And it can have all these different branches. It has branches that go to the columella, it has branches that go to the alis, so it's really tiger country right there. The situation is where are those vessels located? Because wherever they are, I want to go where they're not. And there's no guarantee in life, and there's no 100% safe injection technique. But what I do for the piriform fossa is I inject at one of two levels. I inject intradermal, which you're pretty much safer anywhere on the face, intradermal, except for the tip of the nose, right? Intradermal means that you have to feel resistance on the plunger when you're injecting. That tells you you're inside the dermis and the patient won't like you because it's not a pleasant injection. So that's intradermal because it doesn't want to spread on you, but you know there's no major vessel inside the dermis. Or I have to be on the other side of the sandwich, which is down on bone. Unfortunately, there's nothing, like I said, that's 100%. A certain percentage of those arteries will go ahead because they're so tortuous, and there will be a knob of it that can come down towards the bone. Most of the time, it's going to be, especially in Caucasians, just lateral to the visible fold. In Asians, it can come more medial. That's why they are seeing a lot more problems with injections around the nose than we are because of their specific anatomy. But my injection technique would be with the cannula coming from a lateral approach, staying deep, or would it be with a needle coming from practically behind the patient, okay, angled down and away from the vessels. Whenever there's a vessel, I want to get away from it, and I'm aiming towards the opposite commissure on the mouth, right here. So I come down, and I must feel bone. If I don't feel bone, I don't press. I aspirate. I breathe, I wait, and then I'll inject very slowly, okay? The reason that it's a great area to inject, and one of my favorite areas to inject, is not because I'm an adrenaline junkie where I like to walk off the edge all the time. It's because that as we mature, that area recedes on the skull. The platform goes backwards and upwards a little bit, okay? And as that happens, your nose will spread, and the tip will come down. So you lose the platform or the tripod, just like the tripod that's here for the camera, it's starting to spread out. So the idea is if you want to rejuvenate a face, we want to elevate that area because it's going to lift the bases of the nose, it's going to narrow the nostrils and elevate the tip. It accomplishes so much. Am I going to use a soft product or a firm product there? Firm. So I'm going to use a pure product. It's going to be a higher G prime. Am I going to put in a ton of product? No. I want to put something in that's going to elevate. That'll probably take me about 0.2 cc's, maybe 0.3. And I don't want to dance around with my needle once I find the spot that I feel is the safer area that doesn't have any aspiration. So I'm going to go ahead and put a bolus in over there nice and slow, constantly monitoring the skin of the region and a very slow injection. But the benefit from that is it's going to flatten out the light reflex in the corner of the nose over here, which is the upper part of the nasolabial fold. It's going to elevate the platform so that the nose is going to narrow, the nostrils will narrow, and the tip will come up. It's probably going to do a little support even to the upper lip. Mm-hmm. Some people say that they can elevate the upper lip that way. Did I miss anything? I think that's pretty much the story.
Yeah, that's it.